Good day, students. You are welcome to another video lecture on inborn errors of lipid metabolism. You remember in the past few weeks, we discussed about lipid metabolism, whereby we highlighted the catabolism of lipids, and also we introduced the concept of how lipid molecules can be synthesized. So we also discussed about lipid synthesis or lipid biosynthesis. So in this lecture video, we are going to be discussing about the diseases that are associated with lipid metabolism. So if we look at, before we proceed for the lectures, we need to understand what is the meaning of inborn errors of metabolism. So many childhood conditions are caused by gene mutation that encode specific proteins, and these mutations can result in the alteration of primary protein structure or the amount of protein synthesized. So the functional ability of protein, whether it is an enzyme, receptor, transport vehicle, membrane, or structural element, may be relatively or seriously compromised. So these hereditary biochemical disorders are collectively known as inborn errors of metabolism. So if you remember, our genetic makeup, we have genes that are code for functional products, and the product of those genes are proteins. Some are proteins, and which some of them may be enzymes, they may be receptors for particular membrane, maybe transports, transport vehicles. So, and they have their own specific function. So if there is a defect or mutation in that gene that's supposed to produce that particular protein that is supposed to function maybe as an enzyme, to catalyze a particular reaction in this body. So if the protein is not produced, it means that a reaction will not occur. So generally, the action or the work of that protein is not there at the end of the day. So, and it's generally cause maybe diseases, or disease conditions, So now this is what we term as hereditary biochemical disorders, which they are called inborn errors of metabolism. So how are we going to classify them? We classify them based on what we discussed. We have number one, disorders of fatty acid oxidation. And under this, we will look at defects in beta oxidation, defects in beta oxidation. And under that defect in beta oxidation, we have sudden infant death syndrome, SIDs. We have Zellweger syndrome. We have carnitine deficiency, carnitine palmitoyl transferase deficiency. And D, we have defect in alpha oxidation. And here we'll be discussing about Refsum's disease. And another classification is lipid storage disease. So the previous one are disease disorders that has to do with what? Fatty acid oxidation. So here we have lipid storage diseases. We have Niemann-Pick disease. We have Parvus disease. We have Gaucher's disease, Krabbe disease. Krabbe's disease. We have Tay-Sachs disease. We have Fabry's disease. So, and the third classification is disorders associated with lipoprotein metabolism. So we have those that are associated with hyperlipoproteinemias, and we have type 1 or type 1, which is called familial lipoprotein lipase deficiency. Type 2 is familial hypercholesterolemia. Type 3 is familial dysbeta lipoproteinemia. Type 4 is familial hypertriglyceridemia. And type 5 is combined hyperlipidemias. So, and in under B, we are looking at those that are associated with hypolipoproteinemias, So, and here we have A-beta lipoproteinemia, and B, we have familial alpha lipoprotein deficiency, which we also call Tenger's disease. So, when we look at defects in beta oxidation now, let's talk about number one, which is sudden infant death syndrome. SIDs, and it's a disorder that is due to blockage in beta oxidation. You should know that it's caused as a result of blockage of beta oxidation, and it is there is unexpected death of healthy infants, usually overnight. So unexpected, all of a sudden, then you have an infant dying overnight. So the real cause of SIDs is still unknown. So we have there is now an estimated estimation that at least 10% of SIDS is due to deficiency of medium chain acyl-CoA dehydrogenase. So, and you remember we discussed about this, so you can always refer back to our previous videos if you still want to understand better. But we have discussed it that, and the fact that this acyl-CoA dehydrogenase is the catalyzer specific for a particular range of carbon. Okay, carbon chain fatty acid. We have short chain, very long chain, and we have what medium chain, right? So this is as a result of deficiency of medium chain acyl-CoA dehydrogenase, and the frequency is that 1 in 10,000 births. Okay, so 1 out of 10,000 births suffer this SIDS, and it's more prevalent than phenylketonuria. We will talk about phenylketonuria when we are going to be discussing the diseases that are associated with metabolism of amino acid. So it's more prevalent than phenylketonuria, and occurrence we have hyperglycemia. So number 2 is Zellweger's syndrome, which is also called hepatorenal syndrome. It is rare inherited disorder and is due to the absence of peroxisomes and its enzymes in all tissues. You remember we discussed this, so you can always get back to those materials that we discussed, especially in the class. We have, and then there is a fail, and here we have absence of peroxisome, and there is non-ability to oxidize long-chain fatty acid in the peroxisomes. Okay, as a result, there is accumulation of fatty acid that are of 26 carbon to 36 carbon chain length. And where do you have this accumulation is in brain tissues and other tissues like liver and kidney. So number 3 is carnitine deficiency, and it occurs in newborn babies. We have especially premature infants owing to inadequate synthesis or renal leakage, and in adults it can occur in hemodialysis, okay, and patients with organic acidurias, and carnitine is also lost in urine being conjugated with organic acid. So clinical features include hypoglycemia, and treatments include oral therapy with carnitine. So we have carnitine palmitoyl transferase deficiency, and we have it includes hepatic deficiency of the enzyme resulting in hyperglycemia, hypoglycemia, and low plasma ketone bodies. And we have muscular deficiency of the enzyme produces impaired fatty acid oxidation, which result in recurrent muscle weakness and myoglobinuria. So we have also Jamaican vomiting sickness, which is caused by eating the unripe ackee fruits, which contains a toxin, hypoglycine, that inactivates medium and short chain acyl-CoA dehydrogenase. So this is caused by taking this toxin from unripe fruits, ackee fruits, and it inactivates the enzyme, and you have it inhibits beta oxidation. Because you have inactivated the enzyme, it inhibits beta oxidation. And clinical features include hypoglycemia with excretion of medium and short chain mono and dicarboxylic acids. So defects in alpha oxidation, now we have Raphson's disease, and the enzyme deficiency is phytanate alpha oxidase, and inheritance is occur as a result of what we call autosomal recessive. Okay, when we say autosomal recessive, there is what we call autosomal recessive and autosomal dominant. So when we say a disease is inherited by autosomal recessive order, it means that a child inherited that disease. Okay, the genes for that particular issue error that is going to be caused as a result of inability of the gene to produce that particular protein or product, okay, is inherited from both parents. So the inheritance from both parents that result in this any of this condition is called autosomal recessive. While for dominant, autosomal dominant is where the inheritance occurs from only one parent, either from the mother or from the father. And when we say autosome, you remember autosomes, there are 23 sets of chromosomes, okay, and 22 are autosomes, while one is what they are sex chromosomes, right? So 22 autosomes, right? So that's where we have the autosomal recessive, meaning that the disease is inherited from both parents. Now, the age, it includes from childhood to adult life. And what happens, the biochemical defect, you have phytanic acid that is being converted to pristanic acid, and this is not possible because you have a deficiency of this enzyme, phytanate alpha-oxidase, okay? And you have accumulation in tissues and blood of this phytanic acid, okay? Because it's not being converted to pristanic acid. So blood shows increase up to 20% of the total fatty acid. So clinical manifestations, you have neurological signs and symptoms, sensory disturbance, eye manifestations, you have mental development, usually, here mental development usually is normal, and cerebrospinal fluid, you have increased protein, and also the cell count is normal. And how are you going to diagnose this? You have increased, when you observe increased phytanic acid in plasma. Remember, phytanic acid is not converted to pristanic acid because the enzyme is now deficient. It's not there. Okay, the enzyme to catalyze the reaction is not there. So you have accumulation of phytanic acid in plasma, and the treatment is you should omit intake of dietary phytols, which is the precursor of phytanic acid. So we have lipid storage diseases, and they are also known as sphingolipidosis. They are genetically acquired. These lipid storage diseases, they are genetically acquired, and they are group of inherited diseases that are caused by a genetic defect in the catabolism of lipid containing sphingosine. So when we say sphingolipidosis, they are a group of inherited diseases that are caused by genetic defect in the catabolism of lipid containing sphingosine. They are part of a larger group of lysosomal disorders. Now, features include complex lipid containing ceramide accumulates in cells, particularly neurons, causing neurodegeneration and shortening the lifespan. Remember, neurodegenerative disorders. So this is actually contributing to that. You remember some of the examples of neurodegenerative disorders. We have Parkinson's diseases and Alzheimer's disease, right? So you can relate that with this accumulation of complex lipids, ceramides, and in the neurons, it's causing the neurodegeneration. So, and the rate of synthesis of the stored lipid is normal, and the enzymatic defects is in the lysosomal degradation pathway of what? Sphingolipids. So the extent to which the activity of the affected enzyme is increased is similar in all tissues. So when here, Niemann-Pick disease is actually when you have inability of sphingomyelin to be converted to ceramide. So this enzyme is now blocked. So it's caused by the deficiency of sphingomyelinase. So this sphingomyelin is being converted is broken down to ceramide by sphingomyelinase. So if this enzyme is deficient, it means this reaction will not proceed and you have accumulation of sphingomyelin. Now, principal storage substance is sphingomyelin, which accumulates in the reticuloendothelial cells. And you have liver and spleen enlargement, you have mental retardation as the manifestation. Now, Fabry's disease is caused by deficiency in lysosomal alpha-galactosidase. Okay, you have accumulation of ceramide trihexoside in kidneys of the patient. So in patients that have Fabry's disease, you have accumulation of ceramide trihexoside in kidneys, okay? And sometimes you refer to it as ceramide trihexosidase, okay? So that is the name of the enzyme, okay? So you have what? The enzyme is what, lysosomal alpha-galactosidase, or you can also call it what? Ceramide trihexosidase. So you have skin rash, kidney failure, pains in the lower extremities, and you can now treat it with enzyme replacement therapy, okay? Agalsidase beta, which is now the enzyme that you now give as a therapy, which is now in form of what called Fabrazyme, okay? So Gaucher's disease, you have glucocerebroside being converted to ceramide. So this is now not possible because there is deficiency of lysosomal glucocerebrosidase. That is the enzyme, because it catalyzes the conversion of glucocerebroside to ceramide, and you have increased content of glucocerebroside in the spleen and liver. You have erosion of long bones and pelvis, and you have enzyme replacement as therapy. It's available for the type 1 disease, which is you use what? Imiglucerase or cerezyme, as this is now the enzyme that you use to replace as therapy. So this is also called miglustat or Zavisca, okay, which is an oral drug that can inhibit the enzyme glucosylceramide synthase. Okay, it inhibits glucosylceramide synthase, and essential enzyme for the synthesis of most glycosphingolipids. So it prevents the accumulation of glucocerebroside. So you have Krabbe disease, you have galactosylcerebroside converted to ceramide. So now it is also known as a globoid leukodystrophy. It is caused by deficiency in the lysosomal enzyme galactocerebrosidase, and you have increased amount of galactocerebroside in the white matter of the brain. So it's accumulated in the brain because the enzyme you have inability, the enzyme is deficient, that is to say there is no catalysis of this reaction. This reaction will not occur, and you have accumulation of galactocerebroside in the white matter of the brain. You have Tay-Sachs disease, which is a fatal disease, which is due to deficiency of hexosaminidase, okay, hexosaminidase A, okay. So now the activity of that enzyme is now deficient. So we have accumulation of ganglioside GM2 in the brain of infants, and you have mental retardation, blindness, inability to swallow as clinical manifestation. And you have a cherry red spot develops on the macula, that's back of the eye. And Tay-Sachs children usually die by age 5 and often sooner. So when we look at this table is trying to summarize the disease, the defects, enzyme, the major storage that is associated with the disease, okay, and we have the symptoms. So Niemann-Pick disease, the defective enzyme is sphingomyelinase, okay. Now sphingomyelinase, now you have accumulated products as sphingomyelins, and symptoms: hepatomegaly, splenomegaly, and mental retardation. Fabry disease, you have ceramidase, that is the defective enzyme, and you have accumulation of what? Ceramide, painful and deformed joints. Gaucher's disease, beta glucosidase and glucocerebrosides, okay, hepatomegaly, splenomegaly, osteoporosis, and mental retardation. And Krabbe's disease, you have beta galactosidase, and you have galactocerebrosides accumulated, and you have absence of myelin formation, hepatomegaly, splenomegaly, and mental retardation as the symptoms. So for Tay-Sachs disease, you have hexosaminidase A and as defective enzyme, and you have accumulated ganglioside GM2, and symptoms include blindness, mental retardation, and death within 2 to 3 years. You have Fabry's disease, and alpha glucosidase is deficient, and you have ceramidase trihexoside accumulated, and you have renal failure, skin rash, pain in lower extremities. So are there any treatments? Currently, there is no specific treatment available for most of the lipid storage disorders, although Gaucher and Fabry disease have highly effective enzyme replacement therapies, as we highlighted. There is currently no cure for Niemann-Pick disease, and treatment is supportive. Doctors often prescribe corticosteroids to relieve the pain of Fabry's disease, and anticonvulsant medication are often used to control seizures and in Tay-Sachs disease. So what is the prognosis? The prognosis for lipid storage disorder is determined by the type of disease, the age of onset, and severity of symptoms. Children with Gaucher's disease may live well into adulthood, while children with Niemann-Pick disease most often die at a young age from infection or progressive neurological loss. So children with Fabry's disease often die prematurely of complications from heart disease, renal failure, or stroke. And most children with Fabry's disease die by age 2, usually from lung disease. Children with Tay-Sachs disease may eventually need a feeding tube, and they often die by age 4 from recurring infection. So what research is being done? The National Institute of Neurological Disorders and Stroke and other institute of the National Institute of Health, NIH, conducts research related to lipid storage disease in laboratories, and the NIH and also supports additional research through grants to major medical institutions across the country. And researchers were responsible for developing highly effective enzyme replacement therapies for Gaucher's and Fabry's disease. Scientists at the NINDS continue to study how lipid accumulation in cells and why they cause harm to the body. And the goal of this research is to develop novel approaches to the treatment of these disorders. Okay, now clinical disorders associated with lipoprotein metabolism. We have a hyperlipoproteinemia, and we have type 1 family, which is called familial lipoprotein lipase deficiency. It is a rare disorder characterized by hypertriglyceridemia and hyperchylomicronemia. We have very low density lipoprotein, VLDL, which is now pre-beta lipoproteins, also increased. We have alpha lipoprotein, HDL, high density lipoprotein, and beta lipoprotein, low density lipoprotein. They decrease. And what type of inheritance occurs here? We have autosomal recessive, as you know, I explained that earlier. And the deficiency of which enzyme is deficient here is lipoprotein lipase. So for hyperlipoproteinemia, it is autosomal recessive, and you have lipoprotein lipase deficient. So what is the clinical features? You have recurrent abdominal pain, eruptive xanthomas, hepatomegaly, and in the lab, how are you going to diagnose it? You have what we call a refrigeration test. Here, if the serum of suspected patient is taken in a narrow small tube and is kept in refrigerated temperature for 24 hours undisturbed, a clean zone of chylomicron is seen to float on the top and make a distinct separate layer. So what is the management? You have restriction of fat intake and medium chain triglyceride. So for type 2, which is familial hypercholesterolemia, is a common disorder characterized by increased total cholesterol and high density lipoprotein, and there may be high triacylglycerol and very low density lipoprotein. It is also here it is autosomal dominant. The inheritance is autosomal dominant. Here it means the patient inherited the mutated gene from only one parent, either the mother or the father, and it occurs 1 in 500, so 0.2%. Metabolic defects, there is going to be no enzyme deficiency, but defect of low density lipoprotein receptors. And clinical features include atherosclerosis, CADs, you remember chitin acyl deficiency, okay? And you have corneal actus, and corneal acus, and you have tuberous xanthoma. And the management include low cholesterol diet, decreased intake of saturated fats, and you can also give polyunsaturated fatty acid and drug like statins to manage the condition. Okay, let me quickly revise this type 2 familial hypercholesterolemia. This is a common disorder characterized by increased total cholesterol and high density lipoprotein, and there may be high triacylglycerol and very low density lipoprotein. And its inheritance in form of autosomal dominance, and frequency is 1 in 500, and the metabolic defect is no enzyme deficiency, but defect of low density lipoprotein receptors. And the clinical features include atherosclerosis, CAD, which is coronary artery disease, not the earlier chitin deficiency that I mentioned. It's coronary artery disease, and we have corneal acus and tuberous xanthoma. And management include low cholesterol diet and decreased intake of saturated fat, and also you can give polyunsaturated fatty acid and drug like statin. So for type 3 familial beta lipoproteinemia, it is also called broad beta disease and remnant removal disease. It is characterized by increased low density lipoprotein and very low density lipoprotein. There is rise in intermediate lipoprotein and hypercholesterolemia and hypertriglyceridemia, and we have inheritance is in form of autosomal dominant, and frequency is 1 in 5,000, and metabolic defect is increased ApoE and ApoB, and conversion of normal VLDL to IDL and ITS, and degradation without conversion of IDL or without conversion of LDL. And defect is in remnant metabolism. So clinical features, we have palmaxanthoma, high incidence of vascular disease. Management includes reduction of weight, restriction of fat and cholesterol, and giving polyunsaturated fatty acid and drugs. For type 4, we have familial, which is called familial hypertriglyceridemia, characterized by increased increased triglycerides and VLDL. We have cholesterol may be normal or increased. We have decreased HDL, high density lipoprotein, and low density lipoprotein, as the inheritance is autosomal dominant, and metabolic defect overproduction of VLDL and ApoC2. And clinical features include associated with diabetes mellitus and IHD and obesity. And management is including reduction of weight, restriction of carbohydrates and cholesterol, and hypolipidemic drugs. So type 5 is combined hyperlipidemias, and we have hypercholesterolemia and hypertriglyceridemia, have decreased HDL and LDL. Inheritance is autosomal dominant also. Metabolic defect is secondary to other causes. Clinical features include manifested only in adulthood, xanthomas, abnormal glucose tolerance, and frequency associated with diabetes mellitus and obesity. Management is reduction of weight, high polyunsaturated fatty acid intake, and hypolipidemic drugs. So Wallmann's disease. For Wallmann's disease is also called cholesterol ester storage disease, and there is hypercholesterolemia, and enzyme deficiency include cholesterol ester hydrolase, and in lysosomes, such deficiency in cells of fibroblasts have been demonstrated. So hypolipoproteinemias, hypolipoproteinemias is beta lipoproteinemia, okay? It's a rare inherited disorder characterized by decreased plasma cholesterol due to absence of low-density lipoproteins. There is low triglyceride, no chylomicron, and VLDL formed. And clinical features include malabsorption, mental and physical retardation, and acanthocytosis. Metabolic defects is in defect in the synthesis of ApoB lipoprotein, and leading to the gross deficiency of gross deficiency of ApoB2. Okay, we have gross deficiency. Okay, we defect say it's in the synthesis of ApoB, and leading to the gross deficiency of ApoB, resulting to deficiency of lipoproteins containing ApoB, that is mainly chylomicrons, VLDL, and LDL. So for familial alpha lipoprotein deficiency, also called Tengia's disease, is characterized by deficiency of HDL. In homozygous patients, plasma HDL may be nearly completely absent. And inheritance is in autosomal recessive. Metabolic defects, reduction in ApoA1 and ApoA2, leading to accumulation of cholesterol esters in different tissues. And clinical features include increased risk of coronary artery disease and adenoids. So all these diseases can be diagnosed prenatally, and we say this prenatal diagnosis is before the infant, before the child is born, right? So the disease can be diagnosed while the child is growing in the mother's in the mother's womb. Okay, so we have number one is amniocentesis, which is a procedure, okay, that is used to collect amniotic fluid. You know, amniotic fluid is the function of amniotic fluid serves so many function. So that fluid is now being collected, okay, and you test for so many diseases that are associated with the infant. So we have chorionic villi sampling, okay, whereby you check cells from the placenta, okay, you collect cells from the sample cell from the placenta and check for inborn errors, okay, and birth defects as well. So you have ultrasonography, which is non-surgical, okay. Above two are surgical procedure, but ultrasonography is non-surgical, whereby you use sound waves to send sound waves to check for to take images of vital organs from the patient. Okay, so you have fetal blood sample. This is a surgical procedure whereby blood is collected from the fetus and also is being tested, is going to be tested for birth associated defects. And also there is also maternal blood sample whereby the blood is collected from the mother in order to test for if there's any birth abnormalities. Okay, so that's all for today, and we'll stop here. Thank you for watching. See you next